thank you for the organizers for allowing us to present today. So I just wanted to share a little bit about some of the work we've been doing, specifically looking at management for spinal surgery. So we're a part of the neurosurgery team. It's a very important issue because it can lead to deleterious outcomes for our patients, decreased healing as well as fusion rates. But we'll go through a little bit of like the mechanisms as well. So this is based off of one of our recent papers for our management protocols and how we approach patient care. So it's, as this group is well aware, diabetes is the leading cause of death worldwide. Nearly 30% of adults greater than the age of 65 carry the diagnosis, and it's associated with cardiovascular and renal disease. This is particularly important because most of our surgical patients are within that age group as well, and commonly have a history of diabetes prior to their pre-op management. So a little bit more about the wound factor healing. So there's disrupted VEGF that is contributing to the diabetic wound healing, can lead to poor the retention as well as opening of those wounds over time, so it can have very deleterious outcomes. Also, there's not new ingrowth of blood vessels to promote healing, which can have long-term outcomes for patients, especially if we have placed hardware. So delayed wound healing is a topic that has been proposed by multiple different groups and has been shown due to decreased granulation tissue, decreased neovascularization. It's a pretty serious complication, and the mouse models have shown that this is something that is directly correlational to the theoretic A1C. So we have a very tight algorithm of getting the A1C controlled prior to surgery. So risk factors that have been associated were increased diabetes, increased the metabolic syndrome associated with that, increased BMI have all been associated with poor wound healing after spine surgery. This can lead to increased readmissions, which can have long-term outcomes and consequences for overall recovery. Can also lead to poor fusion rates due to decreased vascularization in the bone marrow as well. So there's an increased risk of reoperation. So ultimately, this has increased cost, but also can lead to adjacent segment disease, can lead to worse pain outcomes. So all things that are directly correlational to patient outcomes. So this is showing that specifically that A1C level is correlated with ultimate the fusion and healing. So particularly, we are aiming for an A1C less than 7 prior to bringing back for elective cases. This is not always something that we're able to do, especially in emergent cases, but for all elective spine surgeries, we tried to work with the endocrinologists and the medicine teams to try to get that A1C less than 7. There's been some improved outcomes in terms of surgical healing. So there, as we've talked about during this conference, there are multiple different medications that my medical colleagues help manage, but whatever is needed to try to get that A1C under control is definitely imperative. We pretty much will not operate on elective patients if their A1C is greater than 7 based on the plethora of data that we now have available. So if there is relevant history that the patient might be at high risk for diabetes, we'll get A1C as soon as they come to our clinic. If the A1C is greater than 10%, then we will work directly with the our medical colleagues to bring that down. And then there's a gray zone between that 7 to 10%, but ideally we try to get it below that 7%. So we screen for patients. So this is something that we do with our anesthesia colleagues pretty consistently, really trying to look at at-risk patients. So we have tried to make an algorithm where we can catch at-risk patients so that we can really focus on factors that would improve wound healing and outcomes for these patients. In the perioperative period, we want to measure blood glucose at least every 2 hours. If they have diabetes, we use a very strict regimen of insulin control as well as a diabetic diet. We hold our oral medications, specifically metformin, due to the need for contrasted studies in selected cases. So we're really using the IV medications. Ultimately, we titrate that per meal. We try to decrease basal insulin by approximately 50%, and we're continually using IV regular insulin. There's some emerging the clinical markers such as the glycosylated serum protein that can give us a little bit better idea of overall management. There's also glycolated albumin. These are still not prime time in most facilities, so A1C is still going to be our gold standard for the near future, but there might be some better options coming down the pipeline. And ultimately, we're trying to use AI technology as well. So we're trying to use the screening protocol to automate the system, catch at-risk patients, try to propose an algorithm that works best for them based on their individual metrics, and it can help stratify patients for how to best manage pre-op as well as in that post-operative period. So in conclusion, there's continued increased need for spinal surgery as the population ages. The incidence of diabetes is extremely high in this population, and it can be associated with complications and poor outcomes. So we're trying to approach this in multiple different methods, very close collaboration with our medical colleagues to get A1C under control, trying to use machine learning to have better outcomes in terms of stratification for patients. And there needs to be more research to guide best practices. But as we have improved diagnostic and treatment options, we're moving in that direction. With that, I'd be happy to take any questions.